And Cindy, would you like me to begin or would you like to begin?
I wasn't sure we're there. So good morning, everyone. Thank you for joining. I think this is our fourth session of Suicide Safer Care in Primary Care Practices. And glad to see all of you here. And I'm going to turn it over to Rick with the Association of Clinicians for the Underserved to get us started.
Thank you, Cindy. And hello, everyone. Thank you so much for joining us and to the Missouri Primary Care Association for collaborating with us on this ongoing series. My name is Rick Brown, and I'm the Director of Communications, Membership, and Special Initiatives with ACU. I'll be your host for today's webinar. For those of you who are new to ACU, we are a transdisciplinary membership network uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help achieve health equity for all. We do that by supporting the healthcare workforce with trainings, technical assistance, advocacy, and more. We invite you to learn more about us, including our ongoing call for abstracts for our upcoming 2024 conference at clinicians.org. If you're interested in more resources on suicide prevention for patients and clinicians as well, you can find more information at our Suicide Safer Care page, where you can find a variety of publications, archived webinars, and more. You can simply scan the QR code to visit, or simply go to bit.ly/suicidesafer, and I'll also put that into the chat. Before we begin, I also just want to go over a few quick housekeeping items. First, we will be recording this session, and we will send you the recording and slides within a week of the webinar. We also encourage you to ask questions via the chat during the presentation as you think of them, or in a dedicated Q&A session at the end. Also, at the conclusion of today's training, please complete our brief evaluation. It's very helpful to help us continue to improve the quality of our trainings. Lastly, I am honored to introduce today's speaker. Dr. Virna is the co-founder and special advisor for advocacy and research at Concert Health. She is also the chief operations officer and co-founder of Zero Overdose, as well as a member of ACU's advisory council. She is a national expert in suicide prevention, a faculty member for Zero Suicide, and previously served for over 2 decades as a senior vice president for a large F2HC network in New York. And with that, I will turn it over to Dr. Little to kick us off.
Well, hello. Good morning, and thank you so much for taking some time. I'm really glad to be here. My name is Virna. I'm a psychologist and social worker by trade. Have been working in primary care literally my whole career. And I know that in the entire time, my bachelor's, master's, doctoral degree, I never got any special training on how actually to care for someone at risk for suicide. And I worked in emergency rooms and I worked in primary care, and people send people to me who are at risk for suicide. And so I'm really glad to be able to talk to all of you. I encourage you, we're not such a huge group. You can feel free to unmute, ask questions, put questions in the chat. I actually do watch that as we go along. Or, feel free to send messages to us privately if you're feeling shy, but very much like to have the conversations so that you can go back and think about your practice. One of the things we know is that the suicide numbers are on the rise. It's not whether or not you're caring for people who are at risk for suicide, you are. The numbers continue to jump. We're actually going to lose well over 50,000 people this year to suicide. Including behavioral health providers. Those numbers are actually on the rise as well. And that's just the people we know about that where suicide was attributed to the death. There's actually probably another 25,000 in there as well, are some of the estimates. So before I really want to just ground us in language. You're going to hear me say died by suicide. We don't say committed suicide. When you think commit a crime, right? We use died by suicide. Also really moving away from language successful or unsuccessful attempts. I've had so many people introduce to me, here's so-and-so, they had an unsuccessful attempt. So you couldn't die by suicide successful, and successful meant you were no longer with us. So moving away from that language, also really changing language. And I see this in charts all the time. And the other day I was actually looking at charts electronically with an organization, a community mental health center. And in one of the charts on the top, in like a flagging patient note session, it had in capital letters, patient is very, very, very manipulative. And I thought to myself, well, that's language that we're actually trying to move away from, because one of the things I know is that I don't pretend to know someone's intent, right? Like, how often in your life have you found yourself saying, well, that wasn't my intent, right? I don't pretend to know someone's intent. What I do know is that if someone's talking about suicide, they're more likely to die by suicide. So I just start there. And it's more important and helpful for my team to say what someone said or did, as opposed to trying to know their intent, that they're manipulative or attention seeking. And you also using words like caring for versus maybe dealing with. So a couple of, sort of brief updates, things to really think about. Many people who die by suicide use guns. And so the number of individuals dying by gun is continuing to increase. What's interesting is that most of the deaths by gun in seniors are suicides. And the numbers from 10 to 14-year-olds are also high. They level out a little in the middle, but more 10 to 14-year-olds and more seniors die by guns as sort of a preferred. Maternal suicide, really interesting. The number of maternal suicides are increasing. One of the things we're learning is that they happen pretty quickly. And so we really have to think about, so if we're bringing people back in 6 weeks after they give birth, then that actually might be too late. The other thing is that it happens really quickly. And Rick, maybe you can help me. We have a video. We're going to see if we can show it. Oh, maybe we don't. We're not able to show it in WebEx. Okay, so that's okay. But one of the things we know is that it happens very quickly. So the video actually talks about a woman who had postpartum depression, had suicidal thoughts and behaviors for a first pregnancy, had a second pregnancy. They had a plan to really start her on medications back in care, and she died within several days after giving birth. And so really what took a couple of months the first time took a couple of days the second time. And so really being prepared. One of the things that we often talk about is not discontinuing medications during pregnancy. So really helpful to start to think about that as well. So youth suicide, the number of suicides in the 10 to 14-year-old population is really, really climbing. Very lethal attempts, hanging, jumping off buildings, guns, depending on the region, it varies a little bit. One of the things that NIMH says is you should routinely be asking 10 and up about suicide. So really rethinking, and oftentimes we, when you're seeing a 10-year-old or a 10-year-old gets referred to you, you're not thinking suicide. You're not even thinking that that child would be thinking about suicide or even know about suicide or be capable of suicide. That is no longer correct information and no longer a way that you should really ground how you approach 10-year-olds. They know about suicide. They probably know someone who died by suicide, whether a celebrity or someone in their circle. And so it's really important to ask them about suicide. And remember, the research overwhelmingly says just asking someone doesn't give them an idea. So we're not giving that child an idea. And just to give you the numbers, and actually it's coming out a little bit higher for 2023. A little more than 10% of high school students are going to attempt suicide. So not think about suicide, actually have a suicide attempt. And when you think about those numbers and you think how many that is in a high school classroom, or if your practice sees 100 adolescents this week, 10 of them are going to have a suicide attempt this year. And so thinking about what that looks like in practice, are you identifying that many kids? But also keep that in mind. If you have a caseload and you're seeing adolescents and you have a caseload of 50 kids, then you're going to have several of them that are going to have a suicide attempt this year. It's always been interesting to me that for geriatric patients, we get fewer referrals for geriatric patients in primary care, because I think people think, well, of course they're sad, they're old, right? But actually they make up just a little under 20% of the suicides. And so really paying attention to the fact that seniors are actually at risk for suicide. One of the biggest risk factors is losing a spouse or a partner. So if you're caring for someone and they're grieving the recent loss of a spouse or partner, you really need to ask them very directly about suicide. If you haven't been to the Zero Suicide website, I encourage you, lots of CEUs there, lots of information. So a couple of things to talk about. So oftentimes, one of the things that I hear from behavioral health providers is I have this long intake to do. I have this big psychosocial assessment, and somewhere buried in there is a question about suicide or suicide risk. And oftentimes I hear behavioral health providers say, like, by the time I get to it, and by the time somebody maybe answers positive, I don't have a lot of time left in my session. And then I have to do all this required stuff. And so what I really encourage is I ask a little bit sooner. And sometimes people will say to me, well, but you haven't really gotten to know somebody, you haven't really built a rapport. And I say, yeah, but oftentimes I just really call that out. And so Lee will talk about that. And so one of the things that I like to do is say, I know we're just getting to know each other, but one of the things I know is many of the people that I see who are struggling with some of the same things you're struggling with start to think about suicide. So I'm wondering if I can ask you whether or not you're thinking about suicide. So I put it out right sooner so that if someone is thinking about suicide, then I can actually have the conversation. I also really encourage you to think about what the responses are that you have when someone tells you they're thinking about suicide. And so we know that oftentimes when people tell us, whether it's a patient, someone at the dinner table, someone in our community, someone in our practice, that oftentimes we're not expecting it. We're kind of on a mission, doing other things, doing a session, doing an intake, having lunch, whatever it is that we're doing. And so it's important to kind of think about some responses ahead of time, because I always say, I know times in my life when I've shared something for the first time, something that I wasn't really sure I should share. And that first couple of seconds after you share it, you're like, you could have a, oh shoot moment, right? Like, oh, I shouldn't have said anything. Or this actually, I'm really glad I said something. It feels good to have told someone. And so when someone tells you they're thinking about suicide, those first couple of seconds are really important. And so it's helpful to think about ahead of time what you might say. Like I always start, thank you for telling me you're thinking about suicide. That right away, thank you, I appreciate it. And I say suicide, right? I don't say you're not okay. I don't say thank you for telling me you're thinking about suicide. And then I want to let them know, hey, you're really important. Your life is really important to me. Your life matters to me. Your life matters to us here at the center. And then I want to give them the one thing that saves more lives than anything else. And that is hope. People who have hope don't often die by suicide. And so I said, it took a lot of strength for you to talk to me today and tell me your thoughts of suicide. I have hope for you. I can see how strong you are. So what I encourage you to do is really practice the 2 or 3 sentences that you would want to say to someone directly after they tell you you're thinking about suicide. It's really important to just sort of have them there. I call them storage statements, to just have them prepared, because then actually you can really go forward and start to get some of the information that you need, because we don't want you to panic. We just want you to use your storage statements. You want to say suicide, you want to give some hope. And it's okay whether someone's on the phone or whether they're in person. We're going to do some of the same things. So you heard me say, ask people what you want to know. Not, are you okay? Are you feeling like hurting yourself, right? Someone actually was doing a role play with me a couple months back, and they asked me, are you okay? And I said, I am not okay today. Like my dishwasher's broken, and then I was late getting on a webinar. No, like I'm not okay. So then we went down a whole rabbit hole, but really what she wanted to know was whether or not I was thinking about suicide. So we want to ask what we want to know. It's kind of like when I used to work in family violence. People who say, well, I ask people if they're okay. That isn't what we want to know. What we want to know is anybody hitting or hurting you at home, right? Ask people directly about suicide. The other thing is we've learned a lot about suicide. When I first got trained, people would tell me, oh, you're going into behavioral health, you're just going to lose some people to suicide. We know that every single suicide is preventable. They are all preventable. We have the ability to save all 75,000 of those lives. They are preventable deaths. The other thing we've learned is that many people who die by suicide don't have a mental illness at the time of death. This is very different than how we used to think about suicide, right? Like, what's the diagnosis? What's the social determinants play a huge role. The housing, the finances, the relationships. People could not have a history of mental illness, not have a mental health diagnosis, and be acutely at risk for suicide. Many people don't have depression. There's sort of this big misnomer that people who have major depression are suicidal, and people who are suicidal have major depression. And yet anxiety is a huge risk factor for suicide. And often we don't even ask our really anxious patients about suicide. We know alcohol and substance use play a role. About a third of them have alcohol or substance use in their, or substances in their system. We also know transitions. And we often think of a transition like coming out of the hospital, but transitions are hospital, medical or mental health, substance abuse treatment, physical rehab, incarceration, a geographic change, a school change for an adolescent. Those transitions really put someone at increased risk for suicide. So anytime there's a transition, we should absolutely be asking about suicide. It's really important for you to know how many people on your caseload are at risk for suicide and be able to track them. One of the things that's super important, and it's there right now, right? In every EMR, the ICD-10 codes for suicide are in the system. Put them on your problem list, put them in your treatment plans, put them in your visit encounters, put them on the problem list. It is so important to do that. One, so you know how many people are at risk, but anyone who sees that patient needs to ask them if they're safe, and we need to be able to know. If I'm covering for you, I'm going to ask different questions or make different decisions if I know someone's at risk for suicide. And so think about what you really want to know and track. And oftentimes behavioral health providers will say, well, my patients don't want suicide risk on the problem list. And I say, well, you know, people sometimes don't want things on the problem list, HIV, STDs, you know, my husband didn't want his kidney level 2 on his problem list, right? Because that affects insurance. And so, but we need to put on the problem list what we are actively caring for someone for. And I always let people know, listen, your life is really important to me. And I put that we talked about your suicidal thoughts in your record, because I want to make sure that every time I see you, or every time my team sees you, or I talk to you, or someone from the site talks to you, we make sure you're safe. And most people are fine. And we want to make sure that we're treating suicide as the problem. One of the things that I know I used to do is be treating the bipolar, or treating the depression, or treating the anxiety, and kind of hoping the suicide went away. Whereas now we are actively treating the suicide. The suicide is the diagnosis. The suicide is the problem. The suicide is what I am actively treating in every single session. And that is way different, or every single contact. And that is way different than how we used to think about caring for someone at risk for suicide. So I know all of you are familiar with these tools. These are the PHQ and the PHQ-A for adolescents. You'll see on the bottom of the PHQ-A, there are questions around suicide. That's the ASQ tool, which we're going to talk about in a moment, because they do advise sort of asking every single time about suicide. So what do we know about question 9 on the PHQ? We know that people who answer yes to question 9 are more likely to die by suicide. So we definitely want to make sure that we're addressing suicide. We also know that it is not the end all be all. Somebody could score negative on question 9 and still be at risk for suicide. And so it's really important to ask a little bit more directly about suicide. So we really want to make sure that we're keeping that in mind. Most places now are adding something in addition to directly ask about suicide. So this is the ASQ. There's actually a toolkit available on the NIMH website. I like the ASQ better for children and adolescents, and I saw, Lee, you asked that in the chat. I like this because it has the scripts for nursing and parents or guardians. I also think the research is a little better for children and adolescents on the ASQ. And to me, I also like question 5. Are you having thoughts of killing yourself right now? If the answer to that is yes, that's a very simple, easy, direct question. If the answer to that is yes, then I go one direction, right? So very clear, very easy to use, evidence-based, really nice toolkit on the NIMH website. I like this personally. A lot of children and adolescent emergency departments use it, a lot of pediatric practices. So I tend to like this for that. That said, the Columbia scale, which we'll talk about now, has a child and adolescent version as well. I don't like it as much I don't think the research is as strong, but we'll talk about using the Columbia scale, and the way that we talk about using the Columbia scale, the child and adolescent version fits into that as well. And so both of those are for children and adolescents, but I tend to like the ASQ a little bit better. So one of the things that we really want to try to do is figure out an appropriate level of care. I used to do something not great, which I used to write, patient has suicidal ideation and a plan, and off they would go to the emergency room, right? That wasn't good care. I'm, not proud of it. And that's because we know now that I can think about suicide, right? And I can know how I would die by suicide. That doesn't necessarily mean that I'm at acute risk for suicide. And we want to make sure that everybody gets an appropriate level of care. We actually know that if we send people to the emergency room for suicide and they're not there appropriately, we can actually put them at more risk. So we want to make sure that the right people get to the right level of care. And there is no emergency room magic. I worked one time in a very large FQHC system, and I looked at the patients that we were sending to the emergency room for suicide risk. It was very discouraging to me to see that many of them were at the end of the day. But also, there was a real misconception about what happened in the emergency room. So I've worked in an emergency room for 17 years, getting referrals from people and being on call for, suicidal patients. And most of them did not need to be there. And that was because they were really not at acute risk for suicide. And what I did in the emergency room, someone could have done in the field. And so we really want to make sure that we're sending the right people there. I did the same tools that we're going to talk about today in the emergency room. I used them. And so we really want to make sure that there's no magic there, right? And it doesn't relieve your liability. Sometimes I hear people say, well, if I send them to the emergency room, then I'm not liable. That's actually not true anymore, because we know the evidence that it could put someone at more risk. The best thing you could do is follow the evidence-based practices that we're talking about today and have a system and a pathway to be able to do this. And if we have some behavioral health leaders on the line and organizations want to put together a suicide safer care pathway, we can help you with that. A lot of health centers and organizations are doing that because we've learned a lot about risk, right? And it's really important to have the tools and to understand risk. And it's a little bit scary. And so that actually is something we need to be comfortable with, to have a conversation around suicide, because suicide is a choice. And I did see a message in the chat. Yeah, a lot of times people think that people are going to be fast tracked to treatment. It's actually not necessarily the case anymore. And people will often be there for days, and you could still work with places to do a planned admission. That actually is way more helpful. And so I think it's probably better, rather than send someone to the emergency room, to work with the hospital or the other place directly, to give them the information that you have a really solid assessment. Here's what they scored. Here's what their risks are. so that they can plan and you can, maybe have someone stay with someone and be safe until they can get to the hospital as opposed to the emergency room. Oftentimes that's an option. But the fast track to treatment, oftentimes, and I know many times I would have someone stay overnight, and by the next day, they knew exactly what to tell me to go home, right? And so oftentimes I knew that if I would have kept someone home and really put a good safety plan in place, I probably could have still got them admitted and got into some different level of treatment. But by the second or third day in the emergency room, they were just done, right? Of just sitting there without a TV, without, any of their stuff. And so really need to sort of take some of that into consideration. So let's really talk about risk. So this is the Columbia scale. A lot of times behavioral health providers will ask me, do you use the longer version of the Columbia scale? And I tell them no, never, to be honest. And actually, I know the creator of the Columbia scale, and I'm sure she doesn't love that I sort of say that. But I don't find it to always be helpful in terms of what I actually need to know and do. And so this is what we affectionately call the primary care version, but it actually is really telling us what we need to know. So you kind of have 3 levels of patients: your yellow, your orange, and your red. And your red, and what really puts someone at risk is intent, right? Have you had these thoughts and had some intention of acting on them, as opposed to I have the thoughts, but I wouldn't do anything about them? And so I have had patients that have had thoughts of suicide for years, some of them, right? That knew how they would die by suicide. And I mean, not just I'll take pills, I'll take these pills, I'll jump from this bridge, I'll jump from this space on this bridge, like very specific. I'm going to go here, I'm going to get this rope, I'm going to go there. Very, very specific plans. And yet when you talk to them, do you intend to buy the rope and die by suicide today? The answer is no. I don't intend to die by suicide today. And so that really lies the difference. And it is, sometimes listening to someone, yes, I think about suicide. Yes, I know how I would die by suicide. And to then say, okay, well, let's put a plan in place, right? Because you're not acutely planning to die by suicide today. So what changes someone to really high risk is their intent. And that is doing something different for those people who score red or who have intent. So again, I can think about suicide, I can have a suicidal ideation, I can have a plan, right? It's really my intent to carry out the plan that kind of changes things. And I weigh things out between protective factors and risk. So I think of it like a seesaw or a teeter-totter, right? And I ask people very directly, because they're here, right? They're with me. They haven't died to this date. So what are some of the reasons you wouldn't die by suicide today? Why haven't you died yet? Why haven't you died by suicide? You've talked to me about, jumping off of the bridge, right? Why haven't you jumped off the bridge to date? What are some of the reasons you wouldn't die by suicide today? Well, healthcare workers will say my patients, right? Or their job, religion, pets. Pets are really important. If I brought my pet to the shelter, they would be euthanized. Your family, spouse, kids, and I reinforce, yes, your children really need their mom, right? I give some reinforcement. If people have reasons for living and don't have intent, that's someone that is going to be at less risk. If somebody has intent and they don't have any reasons for living, then that's someone who's going to be at more risk. And sometimes I will push a little bit. If I ask someone, what are some of the reasons you wouldn't die by suicide today? None. I have nothing. Life is, hopeless. Well, you chose not to die yet by suicide today. Like you're still here. So why, right? Tell me about some of the reasons you haven't died by suicide yet today. if I were going to ask people in your life about some of your reasons to not die by suicide, what would they say? So I sometimes will push a little bit, to talk to someone about reasons for living, and then really understand risk. And then people will say, well, yeah, my parents definitely, would be upset. So it sounds like your parents really care about you and say, so would you say that one of the reasons you haven't died by suicide might be your parents? Yes. Okay. So we do have a reason for living. So like sort of having some of those conversations are often really helpful for people, but I do weigh it out. And you will hear him, whatever it happens to be. And I've heard things that, I really, I spent a lot of time. Someone told me actually not that long ago, they had planted a garden, and put a lot of work into the garden. And the garden was actually, doing very well. She had a greenhouse, she had all this. And she said, nobody would care about my plants, and all of my plants would die. And, I'm getting all this stuff from my greenhouse. And I really went with that with her, because that was her reason for living. And tell me, and sounds like your greenhouse and your plants, and what are you planning to do with those? And we had a whole conversation. And so that was her reason. And so really kind of going with what people are talking about. And that was something that was really important to her. And we were able to use it to talk to her about her risk. And to think about safety planning. So we used to do something called contracting for safety. And we don't do that any longer because we know that it's not safe or a good practice. We do safety planning. And the thing about safety planning to really understand, oops, wait a minute, could I go? Oh, okay. For some reason, my slides are a little out of order here. So a couple things about safety planning to think about, and some misconceptions. Most behavioral health, so I get the opportunity to go in and look at charts, particularly behavioral health charts. And to be honest, I fail about 85% of the safety plans I see in charts. Couple of things to remember. We'll talk about what sort of makes a quality safety plan. Safety planning is a clinical intervention. If I did nothing with Rick but a safety plan, that would be a clinical intervention. That would be a billable session for your PPS rate. That would be a clinical intervention. It is the intervention. It has been shown to save lives. It's an evidence-based clinical intervention. It is what I'm doing in that contact or that session. And a lot of times I still hear people think that it's like this perfunctory document that we have to fill out, and I have to check the box that I did a safety plan. That is really missing the value of doing a safety plan. I love doing safety plans with people because we really have some fun conversations around things that are really important to them and keep them safe. And so it's really important to think about those things in terms of your safety planning. And so when we think about some of the minimum things that we want to do, right, very, very minimum, I give everybody the lifeline, and I put it, actually 988 now is up and running everywhere. I have them put it right in their phone. Sometimes I even say, why don't you give them a call and I'll be right back? Because then they know what to do. The 988 is evidence-based. It's been shown to save lives. It's there 24 hours a day. It's actually been shown to be more effective than mental health treatment in cases. And also, most of the calls to the lifeline are resolved on that call and don't need any follow-up. So I have people put it right in their phone, literally program it in. I love Now Matters Now website, not just because I love the creator Ursula, but also it actually, they're revamping it a little now. So if it looks a little off kilter, it has stories that people can go on. It is evidence-based. It has been shown to reduce suicidal thoughts and behaviors. You can bring it up with people. You can show it to them, save it in their favorites. It actually is incredibly helpful for people. And again, evidence-based, available 24 hours a day. Sometimes I give family, friends, caregivers the Suicide is Different website, really helpful for them. And then you feel like you're giving them something as well that's going to be helpful for them. So before we talk a little bit more about safety planning, this is actually an emergency safety plan that's available on the Now Matters Now website, because we know that risk can change, right? I could not be at risk yesterday and be at much higher risk today. So if we were all in the same room and I asked all of you what to do when you caught on physical fire, every single one of you would tell me stop, drop, and roll. Like, we learned it, we know it. The likelihood that we're going to catch on physical fire is actually pretty low, but every single one of us knows what to do. And we've known pretty much our whole lives. Nobody ever told us what to do if we catch on emotional fire, even though the likelihood of us catching on emotional fire these days is much higher. And so I tell everyone exactly what I just told you and say, listen, I'd really like you to have an emotional fire safety plan. And it turns out some of the same things work. Splashing cold water on my face. If I stop, drop, and roll, what am I not doing? I'm not dying by suicide. I'm breaking those repetitive thoughts. Look in someone's eyes, on my phone, in person, a picture. Those are things that are all really helpful. So you can actually print this off and you can give it to people. And it's incredibly helpful for them to have. And it is important to really think about, then them having the safety plan. I still will do one of the other safety plans, but this actually is often really helpful for people. So this is the Stanley and Brown safety plan. It's the other evidence-based safety plan. Unfortunately, we lost Barbara Stanley this past year. However, this is one of the safety plan tools that is in all of the EMRs, so you're likely pretty familiar with it. Couple of things to think about for safety planning. The first is, and where I often see is, we're going to talk about an activity, right? Can the activity happen at all times of the day, all times of the year? So 365 days a year, 24 hours a day, and can it happen right away? Well, I often see, I'm going to go outside and go for a walk. Is that something I can do when I'm at school or work? Is that something I can do at 2 o'clock in the morning, right? I know that it snows where you are. I have been there when it snows, right? And so it is cold in January. It may not be safe for me to walk at 2 o'clock in the morning in my neighborhood in January or in the snow. So oftentimes I see activities that don't fill all of those buckets. So if I can't go for a walk, then what can I do? I could go on the Now Matters Now website, right? So you really have to make sure you have all of those pieces covered, that it's available all the time. And it's something I can do right away. And if it doesn't fit those boxes, then you've got to work around it. Doesn't mean it can't be there, but you've got to have other things that I'm going to do in case I can't do some of those things. And also, if I'm going to walk, why am I walking there? What about walking there is helpful for me? And if I'm thinking about dying by suicide and I'm going to, die on the train tracks or a bridge, then we want to make sure where I'm walking is not by the train tracks or the bridge or someplace that's not going to be safe to me. How many times has someone said to me, well, I like to listen to that music. It reminds me of the past. Well, is that music that you might be helpful for you to listen to when you're thinking about suicide? So maybe we need to think about music, but maybe some other music that you might want to listen to. Also, calling. So I don't pass a safety plan unless I see phone calls as well. So if you asked me and someone said, so Virna, who would you like to call if you're thinking you're at risk for suicide, and or who's on your team? And maybe I say Rick. Rick is on my team, right? And for those of you who haven't had a chance to meet Rick, he's a wonderful, amazing guy. I don't think I could do the work I do without him, right? So I would call Rick. And so we call Rick. And Rick says, yeah, I would love to be on Virna's safety plan. And then we have that information. And maybe I even ask for consent, that if I don't, I'm not available, that you could call Rick. Maybe Rick says, Virna, I would love to, except I'm really busy working during the day and I can't pick up my phone. So then we say it doesn't mean that Rick doesn't care. Maybe we call 988 instead. Maybe Rick says that's great, but I'm not really sure what to do. So we talk about what maybe Rick could say. We might give him the Suicide is Different website. And I've had this happen too. Maybe Rick says, you know what? I work with Virna sometimes, but I don't want to be on the safety plan. I don't want to do that. And so then we just think about someone else and we can have the conversation. But now we've had all those phone calls. There was a project one time and they went through all the phone numbers that patients had listed on safety plans. And many of them that weren't even correct phone numbers. They were just giving any phone number, right? And so really having the conversation, really doing the safety plan. Sometimes people say to me, well, I call Rick all day, every day. His phone, I have his number memorized. You know what? Sometimes when you're not thinking clearly, it's important to have everything in one place. I want you to have everything in one place that's going to keep you alive and keep you from dying by suicide. And so really making sure that we have everything in one place. So those phone calls are incredibly helpful. Also, Walmart. Why is Walmart on so many safety plans? It's in most communities. You can get there by public transportation. It's open 24 hours a day, right? And so that's why oftentimes you see those on. Also, patient portals. I actually wrote an article about patient portals because it was showing up on so many safety plans. Just knowing that I can communicate with someone was actually really helpful for me, even if someone might not see that message right away. And I ask people, and it's interesting, sometimes I ask people, how can we keep you safe today, right? How can we keep you from dying by suicide? And oftentimes I find people get a little overwhelmed with that question. So I ask it in the past tense. If we were going to have kept you from dying by suicide today, what would we have done? And many times people just find it easier to answer that question. We also want to make sure that activities are personal. So listen to music. What music? Why? Right? And then what's the name of the playlist? I have a lot of patients that have the suicide playlist, not what I would name it, but that's what they name it, right? So whatever the playlist is, very specific artist person. So that oftentimes I see safety plans and it's like, listen to music, take a walk. Those are not things that might be available all times of the day, all times of the year, but also aren't specific and maybe not helpful if I'm at risk for suicide. So the safety plan is going to go through all of those things and cover all of those bases. Couple of frequently asked questions that I get about safety plan. What if my patient doesn't want to complete one? I say, well, one of the things that is really important to me is that you don't die by suicide. Your life is very, very important to me. And I'm going to be really concerned about you if I don't think that you're safe. Can we just take a minute and come up with a couple of things that will help you stay safe, right? And so I really go back to it and ask again. What if I don't have time? First of all, I think it's important to make time. You could actually do something a little bit shorter and give an emergency safety plan if you had to. If they already have a safety plan, I review it. And I say, I see here that you would listen to some music. Tell me more. What music? What, so I often redo it or reinforce it or ask if it's still accurate. If you're sending them to emergency care, I always give them an emergency safety plan anyhow and really try to do something. And oftentimes I start to think, one of the things that we want to do is we want to make sure that you don't die by suicide. And sometimes I give them a copy and say, maybe you could start just thinking about this, because during the time that you're in the emergency room or the hospital, you can think of something and then just add it here, right? So you can almost like this living document that you can just, every time you have an idea, you could put it down here. And that's often super helpful for me. So thinking about lethal means, it is really important to know how someone would die by suicide. If I'm thinking of dying by suicide and using a gun and we keep me safe from that gun, I'm not likely to die by suicide. And also we want to talk about temporary, right? That this doesn't mean you won't be able to go hunting in the fall. It doesn't mean you won't be able to drive again. This is what I do with all of my patients who talk to me about suicide and using their gun. I've also learned to change language around guns. So it's not about taking your gun. You've talked to me today about your thoughts of suicide and using your gun. How can we keep your gun safe so that it's not used to take your life? So that we're keeping your gun safe. How can we keep your gun safe so that it's not used for a reason it wasn't intended? And it's really important to know somebody's preferred method. And also don't assume that it's the medication you're giving someone, like there at the practice. How much medication is in your home? You've talked to me about dying by suicide and using medication. Where would you get the medication? Well, I would get it from my aunt's house because when my grandmother died, she saved bags of it, right? I live next door to CVS. I was actually working with someone one time and they did this really comprehensive safety plan with someone. And then the woman said, well, that's all well and fine, but I actually live down the block from CVS. And so that, to really think about that. Why do I like Amazon pill pack? The individual pill packs save lives. If I have to open all those pill packs, I'm less likely to die by suicide. We know that a delay can save lives. If I have to melt an ice block to get to a key, if I have to open individual pill packs, we know that the more time it takes, the more likely I am not to die. I can't hold a gun. I don't have a gun permit. I can hold ammunition. I can hold the key to a gun cabinet, right? So sometimes you kind of have to be creative, but also be really clear and ask. There's so many. I really think it was recently I was in Montana and there was an adolescent and they had really gone to great lengths to keep his home safe from guns. And then in a follow-up kind of conversation with his counselor, he said, actually, they went to all that trouble. But if I really wanted to die, my grandfather's gun on the mantle is loaded. I go to my friend's house and his father has all kinds of guns in the garage. I go to my grandparents sometimes on the weekends and my grandfather has guns. And so he had actually already thought of other places where he would have access to a gun. And so really asking, where is every place that you have access to a gun that you could use to die by suicide? And so really making sure that you're keeping someone safe. So carrying contacts, I used carrying contacts when I worked at the hospital in primary care. And after I met someone, I would just write a little note. Hey, really glad we had a chance to meet. Hope you're well, Virna, or really looking forward to seeing you next week. We know that that saves lives because, again, you heard me say that hope saves more lives than anything else. People are looking for a reason not to die. And one of the videos that I sometimes show is about a gentleman who jumped off of the Golden Gate Bridge and lived, one of the not many. And he talks about getting up, really thinking about suicide, like just pervasive thoughts about suicide to die that day. And he said, if just one person shows me that they care. And he leaves his apartment, he goes down the street, gets on a bus, like clearly distressed, clearly, crying and saying, if one person, just one person shows me that they care, I won't die today. Gets off the bus, walks to the Golden Gate Bridge, still distressed, right? Visibly distressed. One person shows me that they care, I won't die today. Stands, by the railing. People are passing him by, visibly distressed. He actually describes his tears falling into the water below. A woman comes up to him, taps him on the shoulder, and asks him to take her picture. He does. She walks away and he jumps. He immediately regretted jumping. But essentially, if just one person had shown me that they care, I wouldn't die. People are looking for hope. They are looking for a way to not die. And so these caring contacts are incredibly helpful for people. There's lots of different examples of them to be able to use in practice. So here's some resources often for people. These are some apps that are helpful. One of the things, I like this Not Okay. One of the things that I like to do with the adolescents sometimes, or guys, is a Likert scale. Like 1 is, yeah, I'm pretty safe, not really feeling suicidal. And 10 is like, man, I am on fire. I am on the most suicidal I could possibly be. And then they could send a message, 6, 7, 4. And then people in their network know what to do if someone's a 4 versus a 9, that you can talk to them about what would be helpful for that person based on sort of where they are on that scale. So I often find that that's another way that people can communicate, and then they don't have to tell someone. I don't have to tell someone, listen, I'm really feeling bad. I'm feeling like I want to die by suicide. It's all I can think about, right? And if I send you a 9, then you know that, and we have a plan in place for what to do when I'm a 9. So just, giving some thoughts and suggestions. So I'm gonna stop there. I wanted to we have about 8 minutes to ask any questions. I know there were a couple of questions in the chat that I saw. Yeah, please join the office hours. We always share the slides. Many people are under the impression that if they go to the ER, they will be okay. Yeah, we talked about that. Yeah, I think it's important to ask people. So the question here is, I had a behavioral health provider I work with who asked a patient what was keeping him from jumping off the bridge. And he mentioned, as a plan, he took great offense. I think he misperceived and thought she was telling him to go ahead and jump. He wanted to change counselors. Yeah, so it's hard to know what happened. I think that I often will be really clear, I'm really concerned about you and your life is very important to me. And you've talked to me about, jumping off of the bridge. I'm wondering, can we talk about some reasons you wouldn't jump off the bridge? So I kind of put the preface. And then another comment, it's amazing and disturbing how many patients I get under the age of 13 are suicidal. Heartbreaking. It's absolutely heartbreaking. One of the reasons early on in my suicide safer care work, I had a 12-year-old that came into one of our school-based health centers, was seen the day before and died by suicide the following day, hung in the closet. And it really got me thinking about how to actually ask kids about suicide. And one of the things we know, I worked with a health center recently in Michigan, and they had an adolescent die by suicide in the community, but it was pretty public. And so they called and we talked about the fact that every adolescent in their care was now more at risk for suicide. And every adolescent in their care who was already at risk for suicide was way more at risk for suicide. And one of the things they realized is they didn't actually know how many adolescents in their care were at risk for suicide. It wasn't on the problem list. They had no way to track it. So what they did was they actually put out a memo to staff. They asked every adolescent that they came in about suicide, but it would have been much easier had they been able to know who was at risk for suicide to be able to do some outreach to reach out. So super important to start to think about some of that. So I'm going to stop for the moment. I think we've talked about some of or all of the questions in the chat, and people feel free to unmute yourselves or put questions in the chat. And it's hard. This is hard work. It's hard to talk to people about suicide. you know, but suicide is a choice, and we need to talk to people about choices. Okay, Cindy, I don't know if you wanted to end us today. Looks like we got all our questions out in the chat.
It's good timing. I was just putting in the chat that I needed to jump off for another meeting.
That's right, I remember that.
And I know
Sorry.
there's a few attendees who are coming to the meeting. You can be late if there's more discussion. Don't worry about it. There's some on this that are coming with me. But thank you so much. This is really, I've been doing this since we started Zero Suicide Missouri, how many ever years ago that was, and I learned something new every time. So thank you very much. This was really awesome. And I am going to jump off now.
Okay, thank you. Have a wonderful day. Everyone, thank you so much. I really appreciate your time. I really appreciate, you know, all of your hard work here. Rick did put information on the office hours that we have coming up, which is just open discussion. So feel free to do that. And I wish all of you a wonderful day. Thank you.
Thank you, everyone. Have a good day.